Thank you, everyone. It is now 10 minutes after the hour. I hope everyone had a lovely break. Before we get started, I apologize. I wanted to just announce that Dr. Doran Singh from the FDA was on shortly after roll call, and I neglected to call on him to announce his presence. I believe he's on now. Dr. Fink, just confirming.
Yes, hi, I'm here. Thank you.
Thank you, Dr. Fink. Terrific. We will move on promptly to the influenza session. Dr. Kip Talbot, chair of the Influenza Vaccine Work Group, will provide an introduction and overview of today's session. So Dr. Talbot, the floor is yours.
Thank you. Next slide. I love this group, but really they have done a ton of work and cannot thank them enough. This includes the ACIP members, including Kevin Alt and Camille Cotton and Jamie Lair, the ex officio members, and then we have a lot of consultants because, as you will find out, flu is incredibly complicated and not straightforward. Next slide. So today's work group discussion is going to be a review of vaccines for older adults, and it's going to be an overview of the literature retrieved, the meta-analysis results, the GRADE, and the discussion of a modeling assessment that was done to determine the potential impacts of preferential recommendations for influenza vaccines in this population. And I'd like to stop for a minute and talk a little bit about flu. Flu vaccines have been recommended for adults over 65 and those at high risk for many years now. And actually that recommendation preceded the ACIP and was done by the Surgeon General. Influenza is unique in that we have a brand new vaccine every year. We tend to think of it as one vaccine, but really it's a brand new one every year with 4 different virus strains or parts of viruses. This variation is unique and also coincides with the variation not only in the vaccine strains, but also the circulating virus strains. The data that we have reviewed for older adults has included randomized controlled trials, what we typically think of as the gold standard. But unfortunately, 1 year of data or 2 years of data in an influenza year is equal to 1 year or 2 years of data in influenza. So it was incredibly important that the work group and the work group leads hold all the observational data associated with enhanced vaccines in older adults. This data is incredibly relevant because it will span seasons and give us more data about head-to-head vaccines. This was an incredible amount of work, and I cannot thank my CDC colleagues enough for pulling all of this together. As we review all of this data in a very condensed, dense format, I really hope that the rest of the ACIP voting members can ask questions, and please let us know if there's any kind of context that would help put any of this back into understanding. Next slide. So Dr. Grosskopf is going to give an update on influenza activity. Then Sinead Morris is going to talk about the recommended enhanced seasonal vaccines in adults over 65 and older and what wide-ranging impacts it could have on influenza burden. And lastly, we'll go over that GRADE summary that I was just referring to, and Dr. Grosskopf will lead that. Next slide.
Excellent. Okay, so I'm going to give first today just a brief influenza activity update. Next slide, please. I'm just going to give a very brief update on domestic influenza activity thus far this season. These figures that follow come from CDC's weekly influenza report FluView and are from the most recent report for week 6, that is the week ending February 12, 2022. We're going to start with Neurologic Surveillance. These slides summarize results of influenza positive test results reported to CDC on a weekly basis from surveillance laboratories across the country. They include both clinical laboratories shown on the left and public health laboratories shown on the right.
For virologic surveillance, as we were just discussing, we have clinical laboratories and public health laboratories. In the figure on the left, which is for the clinical laboratories, the black line that you see crawling across is the percent of influenza positive specimens, basically the percent of specimens that were positive. And for the season thus far, that peaked in December at about 6% and subsequently declined to about 2% by mid-January. However, it has started to creep up again, and as of the most recent reporting week, it is 3%. Most positive specimens are influenza A, denoted by the yellow bars. The public health lab figure, which is on the right, shows us that the public health labs are more likely to do subtype testing on the viruses that are sent to them. And so we have some more information about types and subtypes. Red represents H3N2, so you can see most of what we're seeing this season so far are H3N2 viruses. Next slide. This is about ILI, or influenza-like illness activity, and it's from ILINet, which is a network of providers across the country who report weekly to CDC the percent of visits, outpatient visits, that are for ILI. This system uses a symptom-based syndromic definition and not lab-confirmed influenza, so other viruses can be in the mix here. Our current 2021-22 season is the red line with the superimposed triangles. ILI activity peaked in mid to late December and has declined somewhat since and is now below the epidemic threshold. Next slide. Next, influenza hospitalization. This slide presents cumulative hospitalization rate data from FluSurvNet, which collects data on hospitalizations associated with lab-confirmed influenza. Several seasons are represented here. Our current 2021-22 season is the orange line that's near the x-axis. The previous 2020-21 season is the dark blue line, which more or less hugs the x-axis. This season, cumulative hospitalizations are tracking higher than the 2021 season, but are still substantially lower than the previous four seasons, 16, 17 through 1920, which are also on that graph. The cumulative hospitalization rate thus far this season is 4.7 per 100,000. Next slide, please. The last slide shows mortality data for the last few seasons from two sources. On the left, we have the National Center for Health Statistics Mortality Surveillance System, which collects and reports weekly the percent of deaths attributed on death certificates to pneumonia and influenza. Since early 2020, the system has also tracked deaths attributed to COVID-19. The red line denotes the percent of deaths attributed to all causes, while the to all of these causes, while the yellow areas represent pneumonia and influenza, and the blue COVID-19 deaths specifically. For the current week, 22.6% of deaths were attributed to pneumonia, influenza, or COVID-19. The right-hand side of the graph summarizes pediatric mortality associated with lab-confirmed flu, which has been reportable in the United States since 2004. For last season, 2020-21, only one pediatric death was reported. Thus far for 2021-22, a total of 5 deaths have been reported. Next slide. So just in summary, as of week 6, 3% of specimens submitted to the clinical laboratories are positive for that surveillance week after having peaked at 6% at week 50 and declining to about 2% in January. Most specimens that are subtyped are H3N2 viruses. These viruses are thus far genetically closely related to the vaccine virus, but there are some antigenic differences that have developed as H3 viruses have continued to evolve. Sporadic influenza activity continues throughout the country and is increasing in some parts of the country. The cumulative hospitalization rate on FluSurv.net is higher than that for the entire 2020-21 season, but still lower than that observed at this time during the year for the 4 seasons preceding the COVID-19 pandemic. Next slide, please. So after this, I have a very brief update with preliminary interim VE for influenza vaccines from the U.S. Flu VE network. Next slide, please. The U.S. Flu VE network is a network currently of 7 sites and provides estimates of laboratory-confirmed medically attended influenza illness each season. Next slide. The network enrolls outpatients ages 6 months and older with acute respiratory illness and cough of less than or equal to 7 days duration. These results reflect enrollments through January 22nd, 2022. For the season to date, 2,758 persons have been enrolled at the 7 sites. Of these, 147, or 5%, were flu positive, which is fairly low. For the influenza A viruses isolated, all subtype viruses are AH3N2, and all sequence viruses of AH3N2 belong to a single genetic group 3C2A1B, subclade 2A.2. Next slide. So this is a summary of very early preliminary interim VE. These data will be updated as more data become available. So this is something that we'll probably be commenting on more over time. But these are the interim vaccine effectiveness against influenza A and H3N2 among patients aged 6 months and older thus far this season. For influenza A, for all ages, adjusted VE was 8% with a 95% confidence interval of -31 to 36%. And for AH3N2, 14% with a 95% confidence interval of -28 to 43%. Next slide, please. So just a note on some limitations that are important to consider when thinking through this data. This is the lowest influenza positivity rate at 5% observed over the past 10 seasons among U.S. flu VE network participants with respiratory illness. Numbers of influenza positive participants were insufficient to estimate age group specific VE or to compare effectiveness of different influenza vaccine products against the predominant AH3N2 virus. Moreover, healthcare seeking behavior has changed during the COVID-19 pandemic in ways that might affect influenza vaccine effectiveness estimates. Finally, these VE estimates are limited to mild illness, and evaluation of VE against influenza hospitalizations is ongoing this season. And again, these are preliminary interim data, and we expect things to change over time. Thank you very much. Next slide. And just to acknowledge the contributors to the Flu VE Network for the wonderful work they do every year. Thank you.
Thank you, Dr. Groskopf. Next, we'll move on. Well, actually, before I move on, let me just ask if there's any clarifying questions or comments people would like to make or ask. Dr. Brooks.
Yes, can you go back to the VE slide? I think it was just the prior slide.
I think that one.
One further back.
Yeah.
Can you address this again? I just clarified the VE 25 versus 8, and just I'm just missing some in terms of what this slide is showing.
Oh, okay, gladly. So from left to right, we have basically whether it's all flu A or flu A H3N2 subtype. Then just the numbers for flu positive and flu negative among the vaccinated and unvaccinated. And the last two columns are really the data columns. And these are case control data. The Flu VE network uses a test negative case control design. So it's a completely observational design, and as such, prone to biases and confounding that we might not see, of course, in an RCT if properly done. So there's quite a bit of adjustment that goes onto the VE estimates. They're estimated using, I believe, logistic regression modeling, and some of the things that are adjusted for are age, the calendar time of illness onset, for example. There are a number of different factors that go into the model that are potentially confounding factors that might affect your estimate. So the more final estimate is considered to be the adjusted one. Was that what you were asking?
Well, is this saying that the VE for, let's say, A3N2 is 33% versus 14%? I mean, which one of these numbers is the one that is more indicative of the true VE?
Because it's observational data and an adjustment for confounders would be important, it would be the adjusted estimate. So that would be for all A8 and for H3N2 14.
Okay, so 14% VE. All right, thank you.
You're welcome. Thank you.
Dr. Long.
Yes, it's a question and then a comment. We'll comment first. It gets trickier and trickier to talk about percent positive specimens. Now, maybe in this particular study that you're talking about, Dr. Groskopf, you're really talking about respiratory specimens taken because of clinical illnesses.
Right.
But the problem is when you're dealing with percent positives in the middle of a pandemic, and especially with the Omicron surge, for instance, our numbers for influenza in the middle of December would have been about this 6%. But if you delete the aberration of a pandemic and all the specimens that were COVID specimens, you end up with maybe 25, 30% were influenza positive. So it gets to be misleading for, I think, the public to be talking about percents when we don't really know what the denominator is and if any of those were related, the percents were related to a surge of COVID. So can you briefly explain that, and do you understand my point?
I believe I understand your point. I'm not sure I'm the best person to address it, but I don't know if Dr. Fry is on.
Yes, I'm on, but are you specifically referring to the vaccine effectiveness estimate, or are you talking in general about surveillance?
I'm not talking about the vaccine at all. I'm talking about what you have quoted in our material as the peaking of influenza this year was 6% of specimens positive for influenza in mid-December. And I'm saying, except for the aberration of coronavirus, they were 25% positive, excluding those done for coronavirus, and that were coronavirus positive. So I'm asking if the data that you're showing us was specifically accrued to determine what respiratory viruses were circulating, and did it delete coronavirus?
So one thing I can tell you is that we focused on symptomatic people. So the information you're seeing is not asymptomatic people, and I think that's where a lot of the confusion with coronavirus occurs. So if in this particular case, in the surveillance systems that we have, among the people who presented for testing with an acute respiratory illness, we're looking at the percent of those individuals who tested positive for flu. And, you know, there is a percent that is also testing positive for COVID. And this is within people who present with acute respiratory illness, where both COVID and flu are in the differential diagnosis. So, so that's what I can tell you. Certainly, there is, there are different. COVID makes things very complicated with who's being tested, local circulation, and things like that. And so it is hard sometimes to tease everything out completely.
Thank you very much. I'm hoping that we will find a better way to describe activity of a virus rather than percent of positive specimens. Thanks so much.
Thank you. Dr. Talbot, did you want to add anything?
No, I think Dr. Fry covered it incredibly well. Thank you.
Thank you. Okay. I don't see any additional hands raised, so I'd like to suggest we move on to the next presentation by Dr. Morris from CDC on recommending enhanced seasonal flu vaccines in adults age 65 and older and the potential impact on influenza burden. Dr. Morris?
Good afternoon, everyone. Can you hear me okay?
We can, thank you.
Great, thank you. Next slide, please. So I'll just start with a brief overview. Really, our main goal here is to use mathematical modeling to explore how a new preferential recommendation for enhanced vaccines over standard vaccines in adults 65 and over could impact influenza burden over the course of the season. And when I say enhanced vaccines here, I'm referring to the high-dose adjuvanted and recombinant vaccines. So there are two main parts to our approach. First, we create a mathematical model to capture flu dynamics under current guidelines when there's no preferential recommendation in place. And we do this so that we can have a baseline model that we can compare everything else to. And because we know that flu burden can be very different from season to season, we look at two examples. So we consider a high severity season and a low severity season. And these don't represent any one particular season, but you can think of the high severity season as representing a season that's dominated by H3N2 and the low severity season being more similar to one dominated by H1N1. And very briefly, the model that we use is an age-structured SEIR model, meaning that we stratify individuals based on age and disease status. So people start out susceptible, and then upon infection, they progress through a series of states where they're first exposed, but not yet infectious. Then they become infectious and potentially symptomatic. And then finally, they recover and are assumed to be immune for the remainder of the season. We also incorporate vaccination in the model. So anyone under 65 can get a standard vaccine, and anyone 65 and over can get either a standard vaccine or an enhanced vaccine. But the enhanced vaccine will offer greater protection. And we first calibrate this model by taking parameter estimates from the literature and verifying that it can capture the dynamics that we would expect to see in typical high and low severity seasons. Next slide, please. So as an example, this graph shows the epi curve produced by the model for the number of symptomatic cases per 100,000 people. And so the gray curve here is the high severity season, and the purple curve is the low severity season. And we calibrated the model so that the high severity season has a higher and an earlier peak than the low severity season, as is often the case for H3 versus H1 dominated seasons. Also, the light gray rectangle shows when seasons over the last 10 years have peaked, and we use this to verify that the timing of the peaks produced by the model agree with what we have seen in previous years. Next slide, please. We also performed other calibration checks, which I'm happy to talk about at the end if there are questions. But once we're satisfied that the model is producing reasonable dynamics, we then move on to the second step, where we use the model to explore what might happen following a preferential recommendation for enhanced vaccines. So first, we assume that there will be benefits to a new recommendation. So for example, given the choice, more people will choose an enhanced vaccine over a standard vaccine, meaning that the percentage of adults 65 and over getting an enhanced vaccine will increase. But we also explore potential trade-offs that could occur. For example, there could be a delay in people receiving those additional enhanced vaccines if there's higher demand or it takes longer to find a provider that offers that vaccine. And there could also be a reduction in overall coverage in the 65 and over age group. For example, if individuals only offered standard vaccines do not take them. And so we're not considering monetary costs or individual costs like safety here. We're really focusing on the opportunity cost from a societal perspective. Next slide, please. So to model the impacts of a new recommendation, we have to assign values to these benefits and these opportunity costs. So for the benefits, we assume that the percentage of vaccinated adults 65 and over to receive an enhanced vaccine can increase by up to 20% compared with the baseline value with no recommendation. So for example, if the refraction receiving an enhanced vaccine at baseline is 75%, and we assume an increase of 10%, then we would have 85% receiving an enhanced vaccine with the new recommendation. Then for the opportunity cost, we consider 3 different levels of possible delays and reduction in overall coverage. The best case is when both of these are 0, so we have all the benefits above without any additional cost. For the intermediate values, we use a 3-week delay and a 10% reduction in overall coverage. And then for the worst case options, we use a 6-week delay and a 20% reduction in coverage. And I think it's important to point out here that we're not making any assumptions about how likely any of these different costs are to occur. We're just using them to explore a range of possible outcomes. Finally, the bottom table shows 2 other important parameters that we vary in this analysis. First, we assume that enhanced vaccines are between 5 and 50% more effective than standard vaccines, which translates to an effectiveness of 26 to 60% in absolute terms. And this wide range reflects the large variation and uncertainty in estimates from the literature. So this 2014 paper that I cite is just one of the studies that we've used to calibrate this range. Secondly, we assume that at baseline, with no recommendation in place, between 60 and 80% of vaccinees 65 and over receive an enhanced vaccine, with the remaining fraction receiving a standard vaccine. And this range is based on a number of recent studies with some additional uncertainty included. Next slide, please. So to incorporate all these different pieces into the model, we first randomly vary the benefits and those two important enhanced vaccine parameters between the ranges that I outlined on the previous slide, and they're included in the box on the left for reference. So we're directly incorporating the uncertainty in these values into our analysis. Then for each combination of the opportunity cost parameters, we simulate the model with and without a preferential recommendation in place, and we calculate the change in hospitalizations that occurred. And we've done the same analysis for cases and for deaths too, and the overall pattern is the same, so I'm just focusing on hospitalizations here. Next slide, please. So this graph summarizes the main results. There is a lot of information, so I'll try and walk through it step by step. So first, all the panels show the number of hospitalizations that were averted with a new recommendation in place. So positive values means that a positive number were averted, so we had a positive impact. And then negative values means that hospitalizations actually increased, so there was a negative impact. The height of the bars shows the mean outcome across 1,000 different values of the parameters listed on the left, and the error bars are the 95 percentiles. And then the colors show the different seasons, so gray for high severity and purple for low severity. And then each different panel shows a different combination of the opportunity cost parameters. So the delay in receiving additional enhanced vaccine increases down the rows from 0 to 3 to 6 weeks, and the reduction in overall coverage increases across the columns from 0 to 10 to 20%. Next slide, please. So the first important takeaway is that, as we might expect, when both parameters are at their best case values of 0 in the top left, we always see a positive change. So we do better with the recommendation in place. And that makes sense because we have all of the benefits without any of the opportunity cost. Next slide, please. If we stay in that column and move down the rows, we find that increasing the delay while keeping a 0% reduction in overall coverage introduces some potential for negative impacts in the high severity season, but in the low severity season, the impact remains mainly positive. So the benefits can still outweigh the opportunity cost. Next slide, please. However, if we instead increase the reduction in overall coverage to 10% by moving across the middle column, we now always find a negative impact. And this impact increases as the reduction increases to 20% in the right column. And so for the parameter values that we explore here, the opportunity cost can also outweigh the benefits quite substantially. And importantly, the magnitude of this effect is most sensitive to the reduction in overall vaccine coverage. Next slide, please. Before closing, I want to note some of the limitations of our approach and important points to keep in mind when interpreting these results. First, we've seen that vaccines only protect against symptoms, so there's no additional effect on infection or onward transmission. And so our results are focusing on the direct effects of vaccination and don't consider how indirect effects might change these. Secondly, we use the high and low severity seasons to explore a range of possible outcomes that we could expect, but they don't represent any one particular season, and so they're not exact predictions. Thirdly, we don't stratify enhanced vaccines by type, so we don't distinguish between high-dose, adjuvanted, or recombinant vaccines, but we do explore a wide range of parameter values that should account for variations in uptake and effectiveness between these different types. And then finally, our trade-off scenarios do make necessary assumptions about how individual vaccine-seeking behavior might change. And we use these to provide examples of the range of possible outcomes, but we don't assess how likely they are to occur. Next slide, please. So I'll just end by summarizing our main findings. In the best case scenario, with no delays or reductions in overall coverage, a new recommendation always has a positive impact. However, if we switch to the intermediate or worst case values, then we can introduce negative impacts, and these can range from relatively small to more substantial. And overall, we find that these outcomes are most sensitive to the reduction in overall vaccine coverage. And so if we think about what can be done to maximize the chance of having a positive impact, Our results show, as we might expect, that we really want to get as close to the best case scenario as possible and to avoid delays in vaccine uptake, for example, by ensuring timely access to enhanced vaccines, and in particular by minimizing any reductions in overall coverage. So for example, by stressing the importance of still getting a standard vaccine if an enhanced vaccine is not available. Next slide, please. So I just want to acknowledge everyone involved and who provided really valuable feedback, and I'm happy to take any questions.
Thank you, Dr. Morris. This presentation is now open for questions. While we're waiting for hands to be raised, first I want to thank you for an excellent presentation, and wanted to ask, and I'm not sure if this question goes to you or to other colleagues on the call, but based on our current distribution numbers, what is the likelihood that an adult 65 years and older would go to a vaccination site and not have an enhanced vaccine available? And my corollary questions to that also are, is there regional or local variability in that availability that could more adversely impact some communities over others? And then if you can provide an assessment of any potential gaps we need to close from an implementation standpoint. These are all implementation questions, but I don't know if there's any sort of big picture overview our colleagues can offer for how much of an impact a potential shift might have on actual vaccination rates. Dr. Talbot.
I'm sure there's some better numbers that the CDC can give you, but I can tell you that approximately 80% of adults currently get an enhanced vaccine. So it gives you an idea of how much. I think one of the reasons the work group greatly appreciated this presentation was that if we said we would only recommend one vaccine as enhanced vaccine and only give one vaccine as a preferential, and there was a delay in that vaccine, that there may be an issue in the timing of immunization of older adults. If more than one was recommended, it would give more options and reduce the likelihood of a manufacturing issue or a contamination issue, which would then lead to a delay in immunization in older adults. Hope that helps.
Yeah, thank you, Dr. Talbot. Dr. Dries?
Yes, thank you. I guess my broader question is, when would a decision about this preferential recommendation be made? Obviously, we're not voting on it, or you guys aren't voting on it today, but everyone is ordering their flu vaccines for next season now. So if this was to be voted on in June or October, that would be problematic in terms of, most places would not have ordered sufficient supply for an increase in demand. So that would impact uptake as well.
Thank you. Is there somebody in the room who might be able to take these questions? And Dr. Talbot, I see your hand is raised again. Do you want to comment first, and then we'll see if anyone in the room can take the question?
Yes, I think it's a very fair question, and it's always an issue with flu vaccine. As I mentioned, it's a new vaccine every year. So I think the issue is that the full data analyses and the information that you will see in GRADE took slightly longer than anticipated because of the 2-year pandemic that we have all been participating in and continue to participate in. So the GRADE is finally done. The work group has reviewed it and is excited to show the rest of the ACIP voting members the information today. The next steps then would be the evidence to framework. And then at that point, then a vote could be done. So yes, maybe some conflict with influenza purchasing times.
Thanks, Dr. Talbot. Dr. Grosskopf, did you want to add anything?
No, I can't think of anything to add to that. We are hoping to get to that point as quickly as possible, of course, but the pandemic has taken its toll. So we are excited to present the information that we have for the next presentation.
Thank you. Dr. Daly.
Yeah, thanks so much. And thanks for the presentation on the modeling and how clearly that was explained. So I have a question that's probably to Dr. Talbot, but so vaccine supplies is not a major issue here, ? And then my related question is, what do we know about the 20% of older adults who got a standard vaccine? Is that because an enhanced vaccine wasn't available? Is it sort of a logistic and not a vaccine supply issue? Thanks.
Yeah, those are all great questions. So I think I don't have any wood to knock on, but at this point in time, we've not recently had issues with flu vaccine supply, but there have been issues in the past. I think the most memorable was 2005. But currently that is not an issue. So I think there's actually two questions in that you're asking, Dr. Daly. The first is there are 20% who do get vaccinated each year but are not getting enhanced vaccine. And that is probably likely because the place that they have presented to does not have an enhanced vaccine. Currently, there's no preferential recommendation. Many hospitals and healthcare systems do purchase an enhanced vaccine for adults over 65, but not all. I think the second part of the question is really, which you did not ask, but I think is really important, is who's not getting vaccinated, who over 65 is not getting vaccinated. And that's a whole nother question in an area I think that we have some work to improve.
Thank you. We'll move to Dr. Bell, and then I'll end with Dr. Grosskopf in case there's any other comments you'd like to make.
Thank you. I really appreciated this presentation. Dr. Morris, could you go back to the slide where you're showing the results and you're highlighting the best case scenario box? I'm wondering if there's a way to sort of look at the y-axis there and explain in a little bit more detail exactly how much incremental benefit the preferential recommendation might provide.
Thank you. Yes, if it's possible to go to, I believe that's slide 8. Maybe just to,
yeah,
perfect.
Right.
Yeah, so
yeah, go ahead. You get my question?
So you're asking how much effect is the increase or the benefit having?
Right. What are those bars with the error lines? How much is that?
So I don't have the exact numbers off the top of my head, but it's probably about, the mean is maybe 1,000 and the error bar probably goes up to about 3,000.
Okay.
But these aren't, because this is, almost the seasons are modeled on what we kind of expect from typical flu seasons, but they're not fit to any one season in particular. And so they aren't, exact predictions of what will happen. It's just to give an idea. Right.
But the sort of general gestalt here is about 1,000. Okay. That's what I wanted to know. Thank you.
Oh, thank you.
Thank you, Dr. Morris. Any additional comments or questions or responses to questions for CDC colleagues?
Lisa Grosskopf has no further comments.
Okay, thank you, Dr. Grosskopf. And actually, why don't we go ahead and move on to the next presentation, Dr. Grosskopf, and appreciate that you're sharing the GRADE on the influenza vaccine for older adults. I think this will be incredibly helpful.
Thank you very much. Before I start, am I coming in clearly?
Yes, we hear you loud and clear.
Excellent. Okay, next slide, please. Before beginning, I just want to acknowledge and thank the amazing teammates I have and the colleagues who have worked with us on this project. Thank you very much. Next slide. So as described in previous meetings, and most of us are aware, older adults, here defined as those 65 years of age and older, are a group at high risk for influenza-associated morbidity and mortality, but unfortunately also a group for whom influenza vaccines are often less effective than is the case for younger persons. 2 influenza vaccines licensed for this population, the high-dose influenza vaccine, abbreviated HDIIV, and the adjuvanted influenza vaccine, AIIV, as well as the recombinant influenza vaccine, RIV, which is licensed for 18 and older, have been studied against standard dose, unadjuvanted, inactivated influenza vaccines in this population. For this presentation, these 3 vaccines are going to be referred to collectively as EIVs. This review sought to answer the following question. Do the relative benefits and harms of HDIIV, AIIV, and RIV, referred to collectively as EIVs or enhanced influenza vaccines, as compared with one another and with standard dose unadjuvanted influenza vaccines, SDIIVs, favor the use of any one or more of these vaccines over other age-appropriate influenza vaccines for persons aged greater than or equal to 65 years? Next slide. The methods have been presented a couple of times in recent meetings, so we're just going to remind folks of the PICO for this presentation. The population of interest is adults ages 65 years and older. Interventions of interest included enhanced influenza vaccines, that is HDIIV, AIIV, and RIV, both quadrivalent and trivalent formulations. EIVs were compared with standard dose inactivated influenza vaccines, SDIIVs, as well as with one another. 4 benefits and 4 harm outcomes were selected. Benefits included prevention of influenza illnesses, influenza-associated outpatient and ER visits, influenza-associated hospitalizations, and influenza-associated deaths. Harms outcomes included occurrence of any serious adverse events or SAE, solicited injection site reactions grade 3 or higher, solicited systemic adverse reactions grade 3 or higher, and Guillain-Barre Syndrome. Next slide, please. Just to quickly go over some considerations for the data that follows, which is mostly in tables, we have a total of 6 vaccine comparisons. We have the EIVs versus SDIIVs, 3 of those, and EIVs versus one another. Analyses considered influenza vaccines, influenza seasons separately where possible because flu vaccine VE and also relative VE of vaccines to one another varies from season to season. Comparisons of trivalent and quadrivalent vaccines are combined, given data indicating that in general, quadrivalent formulations have been roughly equivalent in terms of safety and immunogenicity to their trivalent counterparts. In cases where a study reported separate estimates for different IIV comparator vaccines, we generally selected the standard dose quadrivalent vaccine, and it's specified as egg or cell-based. We went with the egg-based comparator since that is probably the most likely scenario given the availability of vaccines we have currently. Finally, estimates for composite outcomes are going to be described separately. These are things like combined inpatient and outpatient visits or hospitalizations plus ER visits. Those are not included in the main analyses or grade. Next slide, please. So we're going to start with comparison number 1, high dose versus standard dose inactivated vaccines, or HDIIV versus SDIIV. Next slide, please. This slide and the ones that follow are formatted similarly. The first column contains the outcomes. The second, the study design types contributing to the evidence for each outcome, and you'll sometimes see a mix of study design types, as you can see on this slide, which is probably the most complicated one of the tables in the deck. The third, the number of influenza seasons represented by the studies. You'll see this only in the benefit slides, not the harm slides. Then the pooled risk estimate. Statistically significant results are in red type. And finally, the importance of the outcome and the level of confidence in the effect estimate. So for this first slide, which is benefits outcomes for HDIIV versus SDIIV, we have, next slide, please. For influenza illnesses, the first outcome, high certainty of evidence favoring HDIIV3 over SDIIV3. This is from a single large RCT, including roughly 32,000 persons aged 65 and older, covering 2 influenza seasons, which used a laboratory-confirmed influenza outcome. Next slide, please. There was moderate quality evidence favoring HDIIV for influenza-associated outpatient and ER visits from retrospective cohort studies. This result was downgraded because of risk of bias, given the cohort design of the study and use of a non-lab confirmed influenza outcome. Next slide, please. For hospitalizations, there's unfortunately not an RCT which directly evaluates influenza-specific hospitalizations as a primary outcome. However, 2 RCTs examined hospitalizations and other severe events as a secondary or post-hoc analysis, in one case through review of MEDRA codes associated with serious adverse events that occurred in a previous clinical trial, and in the other through chart review. Neither of these outcome definitions involved influenza testing performed within the context of the study. There was no significant difference with moderate certainty evidence. However, for hospitalization, there's also moderate certainty evidence favoring HDIIV3 against pneumonia and influenza-coded hospitalizations from a cluster randomized trial, as well as from a number of observational studies, primarily of a retrospective cohort design. These were downgraded to moderate certainty on the basis of using diagnostic code defined outcomes rather than lab confirmed flu outcomes. Next slide. Finally, there's moderate certainty evidence favoring HDIIV3 against influenza-associated deaths, which was downgraded primarily because of potential risk of bias from using coded a code-based definition for the outcome. Next slide, please. Moving on to harms, there was high certainty evidence favoring HDIIV3 for SAEs. Next slide, please. For the two reactogenicity outcomes, you can see that the point estimate for the second one in the chart, which is solicited injection site reactions grade 3 or greater, is approximately 4.9, but with a wide confidence interval, so it doesn't meet statistical significance. There was overall low quality evidence for a similar risk of grade 3 or higher local or systemic reactogenicity events, systemic reactogenicity events only, downgraded due to imprecision. Next slide. And finally, for this comparison, Guillain-Barre Syndrome, as you would imagine, it's not easy to study this in an RCT. There was, however, one RCT that reported on Guillain-Barre as an adverse event of special interest to be specified in the protocol. No cases were reported in either group in that paper. Next slide, please. Comparison 2 is adjuvanted inactivated influenza vaccine versus SDIIV. Next slide, please. So among studies comparing AIIV3 with SDIIVs, there are no randomized trials examining laboratory-confirmed influenza outcomes. One RCT, which was really primarily an immunogenicity and safety study, examined clinical effectiveness against influenza-like illness using a symptomatic definition as an exploratory outcome with no lab confirmation. It was not really powered to attest to efficacy. No compatible studies of other sorts were found that could be pooled with these data. This study noted no significant difference in ILI occurrence and was downgraded due to risk of bias concerns given the non-lab confirmed flu outcome. Next slide, please. However, we have some mixed evidence with regard to influenza-associated outpatient visits from a mix of study types. These results can't be pooled into one result because of differences in the statistical analyses and denominator techniques. So there are two separate estimates, one showing a significant difference favoring adjuvanted vaccine and the other no significant difference. Overall quality for this group of studies is moderate, downgraded because most of the data come from studies using code-based rather than lab-confirmed outcomes. Next slide. There's somewhat stronger and more uniform evidence for influenza-associated hospitalizations. This is somewhat more consistent across study designs, similarly to what we see in the last comparison of HDIIV3 versus SDIIV. The pooled estimates favor IIV versus SDIIV with moderate certainty. Next slide. With regard to harms, for safety outcomes, there was no significant difference in the pooled estimate for any SAE, with moderate certainty due to imprecision. Next slide. There is low certainty evidence favoring SDIIV for injection site reactogenicity events. This was downgraded for imprecision due to imprecision of the confidence interval. This result is driven largely from one study, which noted that there were no severe pain events in either vaccine group. Next slide. There was no significant difference in systemic reactogenicity events with downgrading for uncertainty due to imprecision. Next slide. And just to mention, as the slides are changing, that one of the general themes here is that for many of the safety outcomes, that is the main source of downgrading, is the precision of the confidence interval. For our last outcome here for Guillain-Barre Syndrome, there's one RCT, which was adjuvanted versus standard dose, which noted one instance of Guillain-Barre Syndrome in the standard dose, the SDIIV3 group. There's also one retrospective cohort study of 3 seasons from Italy, which noted 0 cases of definite, probable, or possible Guillain-Barre Syndrome in either arm during a 42-day window. Next slide. Next, onto comparison 3. RIV versus SDIIV. First, benefits. We retrieved 2 RCTs addressing influenza illnesses with a pooled estimate showing no significant differences and moderate certainty due to imprecision. Next slide. For influenza-associated hospitalization, there's one retrospective cohort study of CMS data. This estimate favors RIV with moderate certainty. Next slide. Next, harms. For the NASAE and both reactogenicity outcomes, the pooled estimates are all from RCTs and indicate no significant differences. Certainty for all three of these outcomes is low, largely due to imprecision. Next slide. For Guillain-Barre syndrome, there's one retrospective cohort study of trivalent recombinant versus inactivated standard dose vaccine that had this as an outcome. There were 4 cases that all occurred among SDIIV3 recipients, none among the recombinant vaccine recipients that occurred within a 41-day post-vaccination window. Certainty here is very low because of the diagnostic code-based outcome and imprecision. Next slide, please. We're now moving on to comparisons of the EIVs versus one another. There are 3 of these. We're going to start with high dose versus adjuvanted, or HDIIV3 versus AIIV3. Next slide, please. For the illness outcome, there is one small RCT which you're actually going to see for all 3 of the EIV versus EIV comparisons. This is an RCT which included a total of about 90 people, which included all 3 of our intervention vaccines, HDIIV3, AIIV3, and RIV4. It was primarily an immunogenicity and safety study. It included PCR-confirmed ILI only as an exploratory outcome, was not powered for efficacy, and unfortunately, we were not able to find any additional data with which we could pool this data. It is included here for completeness. You'll see the study in the next several comparisons. For this first outcome, there's no significant differences between the HDIIV and AIIV groups. Certainty is downgraded for risk of bias as this was an open label study and imprecision. Next slide, please. For influenza-associated outpatient and ER visits, there are 3 retrospective cohort studies with no significant difference in the pooled estimate. Certainty is downgraded due to the use of a non-laboratory confirmed outcome, and also inconsistency of the estimates that were observed in the study. Next slide, please. For influenza hospitalizations, there are 4 retrospective cohort studies. There's no significant difference between groups in the pooled estimates. Certainty is downgraded due to the use, again, of a non-laboratory confirmed outcome and also imprecision. Next slide. For any SAE, there's low certainty evidence of a similar risk of SAEs. Next slide. And also low certainty evidence for grade 3 or higher injection site or systemic reactogenicity events also being roughly equivalent between the 2 groups. Next slide. For Guillain-Barre syndrome, there's one RCT which included GBS as an adverse event of special interest for this comparison. No cases were reported in the paper for either group. Next slide. Our next comparison is high-dose vaccine versus recombinant vaccine, or HDIIV3 versus RIV. Next slide. Our data become a bit more sparse here, mainly because we don't have as much literature on RIV as we do on the other vaccines. For influenza illnesses, there is the same small RCT mentioned in the last comparison, which examined PCR-confirmed ILI as an exploratory outcome. No significant difference in ILI between the groups. Certainty is downgraded again because of the imprecision due to the small sample size and being an open label study. Next slide. For hospitalizations, there is one retrospective cohort study, a fairly large one, CMS data, but only for 1 season, with an effect estimate favoring RIV4. Certainty is downgraded because of the use of diagnostic code-based outcome data and not lab confirmed data, and also for imprecision for this study. Next slide. For safety outcomes for this comparison, high dose versus recombinant, there are two RCTs which each address the SAE and both reactogenicity outcomes. There are no significant differences between the vaccine groups for any outcomes. Certainty is downgraded for imprecision to low. Next slide. And finally, we're almost at the end, the last comparison, number 6, adjuvanted influenza vaccine versus recombinant influenza vaccine. Next slide. For influenza illness, there's the same small RCT mentioned earlier, no significant difference between the two conditions, downgraded again for imprecision and having been an open label study. Next slide. For hospitalizations, there is one retrospective cohort study with an effect estimate favoring RIV4. Certainty is downgraded to moderate because of the use of diagnostic code-based outcome definitions rather than lab confirmation. Next slide. With regard to harms and safety outcomes for this comparison, there's one RCT which addresses each of the SAE and both reactogenicity outcomes. This study observed no significant differences between the two vaccine groups for any outcomes, and certainty was downgraded for imprecision. Next slide. The next two slides attempt to pull together the evidence across outcomes, first for the EIV versus SDIIV comparison. For HDIIV3 and SDIIV, there's high certainty evidence favoring HDIIV3 for influenza illnesses and moderate certainty evidence for outpatient visits, hospitalizations, and deaths. For safety outcomes, there was high certainty evidence favoring HDIIV3 for SAEs, with the remaining safety outcomes favoring neither vaccine and having low certainty, mainly due to imprecision of estimates. For adjuvanted influenza vaccine, there's moderate certainty evidence favoring neither vaccine for illnesses and outpatient visits, but there's moderate certainty evidence favoring AIVs for hospitalization. For safety outcomes, there's moderate certainty evidence of similar risk of SAEs and low certainty evidence favoring SDIIV for local reactogenicity. For RIV, there is moderate certainty evidence favoring neither vaccine for illnesses and moderate certainty evidence favoring RIV4 for hospitalizations. For SAE and reactogenicity outcomes, there's low certainty evidence of similar risk of these events. Overall, there's relatively little data on Guillain-Barre syndrome with low to very low quality evidence across the three comparisons. Next slide. For comparisons of EIVs versus one another, among the 4 efficacy outcomes, there are no significant differences except moderate certainty evidence favoring RIV4 over both HDIIV3 and AIIV3 for hospitalization. This is on the basis of one observational study conducted over one season. This was a study, a retrospective cohort of CMS data, totaling roughly 13 million people. For safety outcomes, evidence certainty is overall low, mainly due to imprecision of estimates, and there are no significant differences for any outcome. Next slide, please. So just a couple of summary slides. First, with regard to enhanced influenza vaccines versus standard influenza vaccines, overall, we unfortunately have limited RCT data. It would have been wonderful to have more, but we don't have very much. There are mainly 2 studies that examine lab-confirmed flu outcomes, one for high dose and one for recombinant. And these represent relatively few influenza seasons overall. And with influenza, as we attempted to explain during the last meeting, examining seasons is important because of the variability of both VE and relative VE. There's high quality evidence favoring HDIIV3 over SDIIV3 from one RCT specifically for the illness outcome. Evidence for the other outcomes falls more into moderate certainty evidence. From observational data, there's overall moderate certainty evidence favoring each EIV over SDIIV against influenza-related hospitalization, which is an important outcome in this population. The limitations of these data include that they are mostly from large retrospective cohort studies for which outcomes are defined by diagnostic codes rather than laboratory-confirmed influenza. However, they do have a very large sample size and in some cases are conducted over multiple seasons. Moreover, many of them use relatively specific influenza codes rather than pneumonia and influenza codes, although we do have some of the latter as well. The largest quantity of data are available overall for HDIIV3, somewhat less for AIIV3, and the least with regard to hospitalization for one study for RIV. Overall, there are a few differences in safety outcomes and none for critical outcomes. Next slide. With regard to EIVs versus one another, we have more limited data, and in general, only very low certainty RCT data from one study, which really was not intended to examine efficacy as a primary outcome. From observational data, we have moderate quality evidence favoring RIV over both HDIIV3 and AIIV3 against hospitalization. However, this is from one retrospective cohort study conducted over a single season. We really are not observing any safety differences among the three EIV comparisons, and overall evidence providing direct comparison of EIVs with one another does not seem to indicate superiority of any one of these three vaccines over the others. Next slide, please. So finally, overall, there's evidence of benefit favoring each EIV over SDIIVs. The most evidence is available for high-dose vaccines. There are fewer studies and no RCT, including lab-confirmed influenza for adjuvanted vaccines. And we have the fewest studies for RIV overall. There's no strong evidence favoring one EIV over others among studies providing direct comparisons of these vaccines to one another. Limitations include, again, overall few RCT data representing few influenza seasons, and no data reflecting currently available formulations of HDIIV and AIIV. All of the data that we have looked at regarding those two vaccines, high-dose and adjuvanted, reflect the trivalent formulation of the vaccine. Both of those vaccines are now available in quadrivalent formulations only. However, pre-licensure studies generally have indicated similar immunogenicity and safety of quadrivalent vaccines and their trivalent counterparts. Last slide, please. So as far as work group considerations, as Dr. Talbot indicated, the work group has reviewed the GRADE summary and discussed it, and our next step is EtR. Thank you very much. I'd be happy to take questions.
Thank you so much, Dr. Grosskopf. That was an outstanding overview, an amazing amount of data, and you actually did a wonderful job putting it into this GRADE framework and in a very efficient manner, given the amount of data there is. This presentation is now open for questions. Dr. Lair.
Thank you for a spectacular presentation. Could you please go to slide, I'm guessing 53. It's in your supplemental slides, about 5 slides down, and it has the PRISMA study. I'd like to have everyone recognize the amount of work that went into this, and especially if you look at the full text reports assessed, 3,500, and the number of studies that actually got included in the analysis of 49. With no disrespect to other work groups, we're going to be seeing some other diagrams like this later today, where the reports are full text or maybe 60 to 100, and the number of studies were just 7 that got included in the analysis. The amount of work that went into this over the last 2 years is extraordinary. And the amount of work making it in a presentable fashion for the ACIP has been outstanding by Dr. Grosskopf over the last several weeks. And I want to thank the review team and Dr. Grosskopf for all their hard work in making this a presentable presentation. Thank you.
Thank you, Dr. Lair. And agree wholeheartedly. If we could be in the room, we would give you a round of applause, Dr. Grosskopf. Any other questions, comments? Thank you for the chance to present this. Really wonderful. And are there any questions or comments from our liaison members? I just want to give one last round. I do not see any hands raised. I will say it was incredible. Appreciate all the work that you've done to bring it to the stage and recognize there continue to be many implementation considerations we'll have to consider, particularly when we get to the ETR, and looking forward to those discussions. With that, I think we will take a brief break. We are to reconvene. Oh no, we are not taking a break. Apologies. We're going to move right on to the hepatitis vaccine session. Dr. Groskopf gets to take a break after that, but we'll move on to Dr. Alt, who is chair of the hepatitis vaccine work group. Thank you.
Thank you for that introduction. Next slide, please. We've been doing quite a bit in this work group, and we've talked about hepatitis B vaccine as a group lately, also in the working group. Specifically, we talked about universal adult hepatitis B recommendation. We approved that at the end of last year. We've also had a couple of presentations about PREHEVBRIO, which we're going to talk about more today, multi-antigen hepatitis B vaccine that was approved at the end of last year. We had the manufacturer presentation earlier this calendar year. And today we're going to talk about PREHEVBRIO for adult hepatitis B vaccination, including the evidence, recommendation, and grade analysis. Subsequently, the working group will be talking about exploring preferential use of hepatitis B vaccines among specific work groups. Next slide. Vote is not needed today. PREHEVBRIO is going to be added on to our existing adult recommendation as another non-inferior vaccine option to be used with the existing recommendations, as I said. And PREHEVBRIO will become part of the 2023 schedule as appropriate. Next slide. I think the last time that I got to speak about our hepatitis working group, we were running behind schedule. And I skipped over this slide quite quickly, but similar to the flu group, we have a big, diverse group of consultants and subject matter expertise. And I'd like everybody to dwell on this slide for a minute and thank them, including Dr. Sineas, who's my fellow ACIP member on this group. Next slide. That's probably my last slide, actually. So I will turn it over to you, Dr. Lee, for Dr. Wang's presentation.
Thank you, Dr. Alt. And we'll move on to Dr. Mark Wang for his presentation on PREHEVBRIO for adult Hep B vaccination, EtR and GRADE. Thank you.
Thank you, Dr. Lee and Dr. Alt. Good afternoon. This is Lieutenant Commander Mark Wang. I'll be discussing PREHEVBRIO for adult Hep B vaccination, presenting the work group's modified evidence to recommendation and grade. All right, so should PREHEVBRIO be recommended as an option for adults recommended for hepatitis B vaccination? The population is adults greater than or equal to 18 years of age. The intervention is PREHEVBRIO, 3 doses over 6 months. The comparison is existing hepatitis B vaccines licensed for adults in the US. That's Twinrix, Injurix, Recombavax, and HEPLISAV-B. The outcomes considered are hepatitis B virus infection, which the work group deemed critical, serious adverse events deemed critical, and mild adverse events deemed important but not critical. Please note, persons on hemodialysis, pregnant persons, or persons who are breastfeeding are not discussed today in the evidence to recommendations framework. The safety and effectiveness of PREHEVBRIO have not been established in adults on hemodialysis. In addition, there are no adequate and well-controlled studies of PREHEVBRIO in pregnant women. Available human data on PREHEVBRIO administered to pregnant women are insufficient to inform vaccine-associated risks in pregnancy. Data are not available to assess the effects of PREHEVBRIO on the breastfed infant or on milk production or excretion. PREHEVBRIO is a mammalian cell-derived alum-adjuvanted 3-dose hepatitis B vaccine. PREHEVBRIO, like the previously approved Injurix and Recombavax, are all 3-dose vaccines. As we saw at the January 2022 ACIP meeting, Injurix and Recombavax contain the small S antigen, while PREHEVBRIO contains the S antigen in addition to the pre-S1 and pre-S2 antigens, hence 3-antigen vaccine. HEPLISAV-B, approved in 2018, is adjuvanted with CpG 1018 and is a 2-dose single antigen vaccine. In 2021, ACIP approved universal Hep B vaccine recommendations for adults age 19 through 59 years, as reflected in the 2022 adult immunization schedule published last Friday. An additional Hep B vaccine that is safe and non-inferior to existing ACIP-approved Hep B vaccines could be a beneficial adjunct in achieving HHS goals of eliminating viral hepatitis B as a public health threat in the United States by 2030. Our literature search identified 4,148 initial records, of which 1,660 were duplicates. After title and abstract review, 64 records remained for full text review. Of these, 57 records were excluded due to reasons seen on the slide on the right, such as dose response studies, therapeutic vaccination studies, and vertical transmission studies. In total, we ultimately included 7 randomized trials in the GRADE assessment. Despite our PICO question specifying all U.S. licensed Hep B vaccines as comparator vaccines, the 7 included studies found meeting criteria had only Injurix B as a comparator vaccine out of all possible comparator adult Hep B vaccines licensed in the U.S. I present here the GRADE summary of findings based on those 7 studies. Please note that the GRADE process requires pooling across all available studies and uses an intention to treat approach rather than per protocol analysis. The data shown today are also not stratified by age group. Please note also that all studies considered seroprotection as anti-HBs antibody greater or equal to 10 MIU per ml, which is a widely used surrogate marker for prevention of hepatitis B infection. This table is a summary of our GRADE assessment for all 3 outcomes of interest: hepatitis B infection, serious and mild adverse events. For hepatitis B infection assessed via seroprotection, we included 7 studies of randomized trials. In the pooled analysis of these studies, 83.7% of participants achieved seroprotection in the PREHEVBRIO group as compared to 76.7% in the comparison group of single antigen vaccine, which ended up being Injurix for all included studies. The relative risk was 1.07. However, the risk of bias is serious as 3 of the 7 studies contributing to 60% of the weight to the analysis have high risk of bias due to unclear randomization method or lack of allocation concealment and blinding. Inconsistency was rated as serious. I-squared being 89% suggests substantial heterogeneity. The indirectness is not serious for the use of seroprotection with antibody level greater or equal to 10 MIU per ml as a standard measure of the outcome of hepatitis B infection. This brings our certainty of evidence to low. For serious adverse events, or SAEs, 7 studies were included. 4 of these studies reported no SAEs in either PREHEVBRIO or comparator arm, and the pooled analysis shows a relative risk of 1.62 with broad interval of 0.50 to 5.22. The 95% confidence interval cannot exclude the possibility of no meaningful difference, which brings serious imprecision into account. The SAEs in the PREHEVBRIO group are higher, 2.2%, as compared to the Injurix group, 1.3%. The risk of bias is serious for unknown randomization method or lack of allocation concealment and blinding. This brings the certainty of evidence to low. Data for mild adverse events was abstracted from 4 studies with overall risk ratio of 1.09, with the PREHEVBRIO group showing higher proportion of participants reporting mild AEs as compared to the single antigen comparator group with imprecision. With I-squared equal to 89%, the inclusion of studies at risk of bias may contribute to the heterogeneity observed and serious inconsistency. This makes overall certainty low for this outcome of mild adverse events. The evidence suggests that the seroprotection conferred by PREHEVBRIO is non-inferior compared with seroprotection conferred by Injurix. That evidence was established through intention to treat analysis. PREHEVBRIO may result in little to no difference in serious adverse events when compared with those resulting from Injurix. PREHEVBRIO may result in little to no difference in mild adverse events when compared with those resulting from Injurix. Work group judgments. Is the prevention of hepatitis B a problem of public health importance? The work group said yes. For prevention of hepatitis B infection measured by seroprotection, how substantially different are the desirable anticipated effects of PREHEVBRIO compared with those of Injurix B? The work group said minimal. For the outcomes of serious and mild adverse events, how substantially different are the undesirable anticipated effects of PREHEVBRIO compared with those of Injurix B? The work group said minimal. Does the balance between desirable effects and undesirable effects favor PREHEVBRIO or Injurix B? The work group said favors both. What is the overall certainty of evidence for the critical outcomes? The work group said probably not important uncertainty. Equity. What would be the impact of PREHEVBRIO compared to Injurix B on health equity? The work group said probably no impact. Finally, based on similarities of dosage schedule, adjuvant, and vaccine mechanism, the work group perceived that these domains of values, acceptability, resource use, and feasibility for PREHEVBRIO are comparable with the values, acceptability, resource use, and feasibility of previously approved 3-dose comparator vaccines, which included Injurix B. Based on EtR considerations, the balance between PREHEVBRIO and currently used Hep B vaccines is closely balanced, and therefore the work group judgment on adding PREHEVBRIO as an option for Hep B vaccination of adults is as follows. Desirable consequences clearly outweigh undesirable consequences in most settings. The recommendation is as follows. PREHEVBRIO may be used as a Hep B vaccine in persons aged greater than or equal to 18 years recommended for vaccination against HBV infection. Again, persons on hemodialysis, pregnant persons, and persons who are breastfeeding are not discussed in this EtR framework for the reasons mentioned earlier. These were our references. And a big thank you to all our hepatitis work group.
Thank you, Dr. Wang. The presentation is now open for questions. Dr. Long.
Yes, I have a question that you can maybe help us as we have other work groups in mind as well. For the evidence recommendation framework, the very first question is the burden of disease significant? And I noticed this work group answered that question, yes. So they must have interpreted that to mean if there were no other vaccines available. And I wonder from Dr. Wharton or others who have been here longer than I, what is the correct way to interpret this? I mean, if we have 4 or 5, we don't have an unmet clinical need at the moment for more hepatitis B vaccines that you told us about, at least. So how are we to interpret these evidence to recommendations when we have other vaccines in the field?
Dr. Long, this is Melinda Wharton. Thank you for that question. Actually, in this circumstance where this vaccine is an additional vaccine for indications that ACIP has already voted on, that domain of the EtR actually, from my perspective, wasn't even necessary to address because the committee already has weighed in on hepatitis B as a public health problem, as reflected in the recent vote by the committee to recommend hepatitis B vaccination for all adults. So I think this is sort of a settled matter in terms of the committee's take on the public health importance of hepatitis B prevention. I think it probably was a little confusing because other components of the EtR were presented comparatively, but in terms of the public health problem, I think that we accept that hepatitis B is a important public health problem and prevention's important, and we recommend that adults be vaccinated to prevent it. And with availability of this product, we have an additional modality to accomplish that.
Thank you.
Thank you. Dr. Alt, did you want to also comment? or did you have a separate comment?
I did. I'm having trouble navigating back and forth between screens because I pulled up the hepatitis slides from November when Dr. Wang spoke last time. 20,000 new cases every year, $1 billion spent on hepatitis B, and about 2 million Americans living with hepatitis B. And, you know, we talked about this as Dr. Wharton said, but I wanted to add some data.
Thank you, Dr. Alt. Dr. Paling.
Yes, thank you for a great presentation. It's very clear. And I actually have a procedural question because this is a new vaccine. And are we supposed to vote on a new vaccine, recognizing it would still go into the same recommendations? Thank you for the clarification.
This is Melinda Wharton again. Given the existing recommendations for ACIP for vaccination of adults to prevent hepatitis B and the similarity of this product in usage to other licensed products, and the fact that we're not adding it to the VFC program, no vote is necessary, but we do want to have public discussion. And of course, you know, as documents are updated, this vaccine will be included as an available, acceptable vaccine to use for prevention of hepatitis B in the United States.
Thank you, Dr. Wharton. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as an individual practicing physician. I have a question about this triple antigen vaccine. And I was looking at the December 21st, 2021 ACIP presentation, specifically with slide 24. This is the one from the company. And the headline of this slide was Improved Immunogenicity in Key High-Risk Groups and Investigator-Initiated Studies. And it specifically mentioned end-stage renal disease, HIV, and non or low responders. Would that sort of nuance be included in guidance regarding this vaccine?
Hi, this is Mark Wang. Thank you for that question. For this question, we looked at the generally healthy population, did not look at what I'll call special populations. Those were excluded from this study. The next term of reference that the work group will examine will include some of those populations that you mentioned.
Thank you.
Thank you. Are there any additional questions? I don't see any additional hands raised. So with that, if there's nothing else, we'll move on. Actually, now we will get a break. I'm going to actually suggest that we take a 12-minute break. So let me see if I can even add correctly. So at 38 minutes after the hour, let's plan to reconvene. I would like to meet just a couple of minutes early. Apologies. At 53 minutes, let's make it 55 minutes after the hour. So we'll reconvene at 55 minutes after the hour, and we'll meet with the MMR vaccine work group. Thanks, everyone.